welcome to everyone. I know that you are joining in. I bring you greetings from the American Academy of Developmental Medicine and Dentistry. Welcome to our virtual grand rounds. Tonight is entitled Diagnosis and Treatment of Tardive Dyskinesia in the IDD Population. I am Deanne Shinkett-Wells, the president of the AADMD. As you know, this is an organization of dedicated professionals, persons with lived experiences, nurses, physicians, dentists, occupational therapists, you name it. And we are all about assuring that there is universal quality care for populations with intellectual and developmental disabilities. If you enjoy education and networking and just being a part of a community that cares for those with disabilities, please join us at our conference. We are going to be in Dallas, Texas. And as you see, the name is Saddle Up. So get your cowboy boots ready and your cowboy hats ready. We are going to be learning and educating each other. And how do we thrive as we care for those with disabilities and assure that our patients thrive as well too. I'd like to introduce you to our student moderator. She is Riley Miller, and she will take it from here, introducing our speaker for the evening. Thank you.
Hi, everyone. Thank you so much for being here today. Today, we are lucky to be joined by Kendra Davies. Kendra Davies earned her bachelor's and doctorate degrees in pharmacy from the Ohio State University College of Pharmacy. She then completed a specialty pharmacy residency in neuropsychiatry at the Ohio State University Medical Center. After training, Kendra was hired as the first clinical pharmacy specialist in psychiatry at the Johns Hopkins Hospital in Baltimore, Maryland, covering all inpatient psychiatry and neurology units, and also established Johns Hopkins' first pharmacy residency in neuropsychiatry. Kendra transitioned full-time into the pharmaceutical industry in 2004 and has held a variety of positions within medical affairs across the industry, including MSL, Medical Director, MSL Management, and Market Access Health Outcomes Liaison roles. She is currently Associate Director of Medical Affairs for Neurocrine, focused on organized customers, including long-term care ownership groups, LTC pharmacies, provider service organizations, and LTC organizations. So thank you, Kendra, again for joining us today. We wanted to get started with a quick poll just to see everyone's background. So once that pops up, if everyone could please answer that.
All right, it looks like most people voted. I'm going to go ahead and end the poll in 3, 2, 1. I'm going to end it and share the results.
Okay, great. So it looks like we have some practicing physicians, dentists, other clinicians, residents. So we have a good variety. Thank you all for being here. And there will be a Q&A at the end. So if you have any questions throughout the presentation, please drop them in the Q&A chat box and we'll be monitoring that. So with that, I'll turn it over to you, Kendra. Thank you again for being here.
Thank you, Riley. That was a full intro. And hang on one second. Let me get to my actual presentation. There we go. And of course, my internet connection is unstable, so I'm going to go off video and come back on at the end. But welcome everybody this evening to the Grand Rounds, and I so appreciate you being here this evening. I know we're coming from multiple different locations across the country, so wherever you're coming from, welcome. And tonight we're going to discuss the differential diagnosis of drug-induced movement disorders and specifically the treatment of tardive dyskinesia in the IDD setting. So I hope you'll find some good clinical pearls from this and would love to have this be interactive. If you have any questions, please put those in the Q&A and the chat. And I can't wait to see what y'all think of this. So that I'm going to get started. Slides will advance. Always takes a minute here. There we go. So as an introduction, I'm sure you're all aware that there has been a huge increase in the use of antipsychotics, specifically in the last few decades with the advent of the second generation class of antipsychotics. There's a lot of different reasons for this, as you can imagine, primarily a lot of the broadening indications for these second generation drugs, including into mood disorders, autistic spectrum disorders, as I'm sure you're well aware in your population, being utilized more so in the pediatric population, as well as off-label use in behavioral disturbances and dementia populations. So there was this explosion in use with the advent of the second generation class. And with that, we really thought back in the 90s when these drugs were first introduced, that the second generation class would sort of be the holy grail of treatment and mitigate some of the issues that we saw with the first generation class, primarily these movement disorders that we're going to talk about this evening. So unfortunately, as the drugs came out in the second generation class, we were starting to recognize that indeed, while the incidence of these movement disorders was less with the second generation class, they were still occurring at a pretty good rate. And by that time, the cat was already out of the bag, and these drugs were being utilized broadly in a lot of different indications and a much broader population base. So because of that, even though the incidence of these movement disorders is much less, because the population is so much bigger than what the first generation drug class was utilized in, we're seeing still a lot of these movement disorders. And specifically, we're still seeing tardive dyskinesia, even with the second generation class of antipsychotics. So as you can see from this chart, this goes from 1992 through 2020. There was a fourfold increase in the last 25 years. And as you can see here, this is an estimate from 2018. So these data are actually outdated. And so there's actually an underestimate in terms of what and how many of these drugs are currently being prescribed. And, you know, every year there tends to be another antipsychotic that's approved. The good news is that we have some new mechanisms that are coming out in the antipsychotic class. Actually, Neurocrine has one in the pipeline that we're really excited about. Different mechanisms mean, you know, possibly reaching a different type of population that might get benefits from these newer drugs. But suffice it to say, these drugs are not going away, and obviously you're seeing them used a lot in your population. And we believe there's up to about 50% of the IDD population that's currently utilizing antipsychotics. So definitely they're at risk for these movement disorders. So dopamine receptor blocking agent, abbreviated as DRBA, these I will just call antipsychotics for ease and simplicity. There's other drugs that do block dopamine that we're going to talk about, but specifically we're going to talk about more so the antipsychotic class. And again, these drugs can cause these movement disorders. Now, these movement disorders historically have been called extrapyramidal side effects or extrapyramidal symptoms. We believe this should be an outdated term, an outdated terminology, because essentially what the EPS is an umbrella term that describes all of the movement disorders as one. And unfortunately, what that leads to is oftentimes misdiagnosis and mistreatment of the particular movement disorder. And it's important to recognize that these movement disorders are very different in terms of their underlying pathophysiology, the timeline in which they present, the symptoms, their presentation, and most importantly, the treatment. And if you are calling one movement disorder something different and you're treating it with a certain drug, you might actually be exacerbating the another movement disorder and also putting them at risk for additional side effects. And it turns out that tardive dyskinesia is a very different movement disorder from the others that we're going to discuss. It's very clinically distinct, and it does require specific management that's very different from the other movement disorders that we're going to talk about. So again, looking at the 4 different movement disorders that we're going to dive into this evening, extrapyramidal symptoms, again, should be an obsolete term, should no longer be used. And we really encourage everybody to utilize the actual specific movement disorder when you're describing these so that you understand, again, what the underlying pathophysiology is and the different treatments that are required. So the first that shows up when you utilize an antipsychotic, and probably the most severe in terms of potential for an emergency, is acute dystonic reactions. The good news is that acute dystonic reactions are probably the most rare of any of these movement disorders. They tend to be more commonly seen when you use high doses, specifically with IM antipsychotics. We utilize this a lot in the inpatient setting, especially with the first generation drug Haldol. We would see acute dystonic reactions in the inpatient setting a lot. That tends not to occur these days with the advent, again, of these second generation drugs that have a lesser incidence of this, but this is considered an acute medical emergency and needs to be treated urgently. And we'll talk about these more in detail in a moment. The second is akathisia, which can occur within days to months of onset of treatment with antipsychotics. This is described as an inner sense of restlessness with a compulsion to move. And this is kind of tricky because it can be misdiagnosed as other things like ADD, stereotypies, especially in the autism spectrum class, stimming in the autism spectrum population. So this one might be one of the more difficult ones in terms of differential diagnosis. But we'll talk about how to recognize this. Drug-induced Parkinsonism literally looks just like idiopathic Parkinson's disease. This tends to occur within days to months of onset of treatment. And again, we'll look at the symptoms, but it looks just like an idiopathic Parkinson's patient. And then finally, again, tardive dyskinesia. This is a very distinct movement disorder. As the name implies, tardive is delayed or late onset dyskinesia, as these abnormal movements. And this tends to occur within months to years of onset after being exposed to these drugs. So taking a deeper dive into each of these movement disorders, again, dystonia tends to occur acutely within hours to days of being exposed to an antipsychotic. Again, it tends to occur more often with high dose IM antipsychotics. So hopefully you have not seen this, but essentially the movements can be pulling, twisting, sustained, repetitive movements. They're very painful. Postures, they're usually focally involving the head, the neck, the eyes. So you can see, this torticollis that can occur, which I'll show you in a moment, oculogyrate crisis of the eyes, trismus of the mouth and the jaw, tongue fasciculations, and facial grimacing. This, again, can be very, very painful and requires immediate treatment. So this is a video of a young lady experiencing an acute dystonic reaction. You can see that her neck is contracted. She's experiencing a lot of pain in her neck. She's having a difficulty moving her neck. It's stuck in that position. And she's also having difficulty opening and closing her jaw. So again, this would be considered a medical emergency, and especially if it's affecting the larynx. So if it's affecting the larynx and there's a laryngospasm, that can cause respiratory stridor and respiratory depression. And again, definitely is considered an acute medical emergency and needs to be treated urgently. So the treatment for acute dystonic reactions, the first line treatment would be an anticholinergic, specifically benztropine or cogentin, or trihexyphenidyl or Artane. You can give benztropine IM in a medical emergency. You can also give diphenhydramine or Benadryl, which is both an antihistamine and anticholinergic, and you can also give that IM in an emergent setting. Second line would be considered benzodiazepines. The second one, as I mentioned prior, is akathisia. This tends to occur within days to months of exposure of antipsychotics. And again, this is described as this really horrible inner sense of restlessness with an urge and compulsion to move. So that restlessness is not alleviated until the individual moves in some way. So you tend to see they can't sit still. It's like they have ants in their pants. They're constantly shuffling, shifting their weight, rocking back and forth. The way I like to describe it is if you've ever had restless legs at night when you're trying to fall asleep, you know how uncomfortable that feeling is. And in order to alleviate that restlessness, you have to get up, walk around, shuffle your legs until that inner sense of restlessness, that feeling, that horrible feeling goes away. Well, imagine that's occurring in your entire body, not just your legs, but it's happening in your entire body 24/7. You can imagine how uncomfortable that feeling would be. And of course, this is going to cause a lot of behavioral manifestations, specifically in the IDD population, where they may not be able to verbalize what they're experiencing or describe what they're experiencing. They may act out behaviorally in many different ways. So again, this might be a little bit more difficult to identify, especially if you have an individual that has a lot of stereotypies at baseline, if they have less stimming behaviors. So it could be difficult to differentiate in those individuals. But this is an example of a lady who's experiencing acute akathisia. She's being asked to sit still. And as you can see here, she's not very happy about being asked to sit still. She's constantly shuffling, moving her legs. Her legs are jumping up and down. She definitely does not want to be sitting still. She wants to get up. It's almost like she's got ants in her pants. It's a very, very uncomfortable feeling. And the treatment for this is a little bit different in terms of the APA guidelines. The first thing you want to do, if possible, is to lower the dose of the antipsychotic. This does tend to be a dose-related phenomenon with these drugs. So if you can, you want to reduce the dose of the antipsychotic. If that doesn't help, you want to consider switching to another antipsychotic that's maybe less potent in terms of dopamine blockade to alleviate the akathisia. But if that doesn't work, or if they're on a good dose and they're being, well treated with whatever they're being treated for with the antipsychotic, then you want to add on a beta blocker. So we believe the underlying pathophysiology of this is very different from the other movement disorders in that this is more of a noradrenergic tone issue in the brain. And so beta blockers really are the drug of choice, and specifically propranolol or Inderal is the drug of choice because this passes the blood-brain barrier. Some of the other beta blockers only act peripherally and don't cross the blood-brain barrier. Propranolol is very CNS active, so giving propranolol or Inderal is the best treatment for akathisia. Second line would be considered benzodiazepines. And finally, as I mentioned, drug-induced Parkinsonism. This is probably the most common of all of the different movement disorders that we're going to talk about this evening. This tends to occur within days or possibly weeks, sometimes years of onset after treatment. Again, this looks identical to idiopathic Parkinson's disease. And the reason for that is because when you're blocking dopamine in the area of the brain, which is called the nigrostriatal pathway of the brain, this is the area of the brain that's responsible for movement, coordinated movement. And with Parkinson's disease, what happens in the nigrostriatal pathway is that there is a destruction of the dopamine neurons in that pathway over time. And by the time someone's diagnosed with Parkinson's disease, about 70% of those neurons are already depleted. They're already gone. They're already destroyed. And so you see these symptoms consistent with Parkinson's disease, which include bradykinesia, which is basically everything is slowed down. You see this specific pill rolling tremor. You see a rigidity in the neck, the trunk, and extremities. It's specifically cogwheel rigidity, where when you are basically testing their joints, you can literally feel, for instance, in the elbow, if you're testing them for rigidity, it literally feels like a cogwheel, very ratchety kind of feeling in their joints. You can feel it in their wrists, you can feel it in their elbows, you can feel it in their knees, their ankles. So that's a good way to test for rigidity that is Parkinsonism in quality. Hypomemia, so reduced blink rate. So if they're blinking slower than you, that's a good indication that they might have some Parkinsonism going on. They have a reduced arm swing, flexed posture when they're walking, slow shuffling or freezing gait. There's also something called rabbit syndrome, which is a Parkinsonian variant that is just of the lower jaw. That's a fast tremor. There's also very soft speech. They can have obviously dysphagia associated with this and fatigue. So this is a really good depiction of a young lady who is way too young to have Parkinson's disease, but she looks just like a Parkinson's patient. So you can see that she has this pill rolling tremor in her hands. She's got the masked face, so she's expressionless. She's barely blinking at all So again, that rule of thumb of blinking is really important. Flat affect, if she was walking, she would have a very slow, hunched over posture, a shuffling gait. She probably has freezing when she tries to pivot or walk. So this is a really good depiction of Parkinsonism. So how do we treat this? Well, again, similar to akathisia, the first line is you want to lower the dose of the antipsychotic or switch to a less potent antipsychotic to perhaps alleviate the Parkinsonism. Again, if that's not possible, if they're on a good medication and they're getting benefits otherwise, then you have no other choice but to treat the Parkinsonism with an anticholinergic such as benztropine or trihexyphenidyl. Again, the brand names would be cogentin and Artane, or diphenhydramine or Benadryl. The issue with this that we'll talk about a little bit further in subsequent slides is that when you treat with anticholinergics, whether you're treating the possibly acute dystonic reaction or in this case Parkinsonism, unfortunately you're putting the individual at risk for tardive dyskinesia down the road. And if they have tardive dyskinesia, it can actually exacerbate the symptoms of tardive dyskinesia and make it worse. So there's another drug called amantadine that's a very interesting drug that actually works on the NMDA receptors in the brain. It's a fascinating drug. It's actually used for the flu as well, and actually has some dopaminergic properties as well as anticholinergic effects. So this might be another option if you have an individual that has both Parkinsonism as well as tardive dyskinesia, or if you're trying to avoid the use of anticholinergics, potent anticholinergics, then amantadine might be a good choice. Okay, so moving on to the diagnosis of tardive dyskinesia. So first off, looking at the annual incidence with these different medications and different classes. So with the first generation drugs, you can see that the annual incidence of TD is up to about 7% with that first generation class of drugs. If only exposed to second generation drugs, the incidence falls to about 2 to 3%, which is a lot less, as you can see. But again, keep in mind the amount of individuals that are now being exposed to these medications. And most commonly, if someone's been exposed to a second generation drug, they've probably at some point in time been exposed to a first generation drug. Think about if an individual is transferred from, say, a long-term care setting into an acute care setting, maybe for a UTI or pneumonia. They get delirious and they're put on an antipsychotic inpatient to treat delirium. So they're probably going to be exposed to a first generation drug. In that instance, hopefully they won't be, but especially in the elderly population, most of them, especially in the long-term care setting, have at some point been exposed to a first generation drug. So when you look at the prevalence rate, so lifetime prevalence, when you're exposed to a first generation drug, up to a third may be at risk to develop tardive dyskinesia. With the second generation class, when you don't know whether or not they've been on a first generation drug, that is about 20 to 25%. So about a quarter, a fifth to a quarter of prevalence for tardive dyskinesia lifetime. And then finally, if you know for certain that they've only been exposed to a second generation drug, that prevalence is much less, but again, the chances of them having been exposed to first generation drug is pretty good. So at this point in time, we believe that there are at least 800,000 adults in the United States that have tardive dyskinesia. The downside of this is that it is still greatly underrecognized and often misdiagnosed, mostly as drug-induced Parkinsonism, and therefore it's being mistreated with anticholinergics. In fact, there's some data to show that about a third of patients that have tardive dyskinesia are actually being treated by anticholinergics, which again, as I mentioned, can exacerbate tardive dyskinesia and make it worse. So as of now, we believe that only about 40% are diagnosed with tardive dyskinesia, and that means there's about 60% that remain undiagnosed in the US. So we need to do a much better job at recognizing these individuals. And even worse, of those that are diagnosed, only about 20 to 30% are being currently treated with the VMAT2 inhibitor, which is the only FDA-approved treatment for tardive dyskinesia. So again, this is why, despite the fact that these drugs have been approved since 2017, there's still a vast underestimate, a vast under-recognition, underdiagnosis, and under-treatment of tardive dyskinesia, which is a travesty because This tardive dyskinesia has actually been around since the 1950s. It was first described shortly after the antipsychotics were approved by the FDA back in the 1950s. And really, there's been no treatment available for tardive dyskinesia up until these VMAT2 inhibitors were finally approved by the FDA in 2017. So it's a shame that despite there being treatments available, there's this therapeutic nihilism in the psychiatry world where, at the time there was nothing that we could do for tardive dyskinesia patients. So basically they just threw up their hands and said, well, there's nothing we can do. You're just going to have to live with it. And basically the only thing that we could do back in the day before VMAT2s were available was to increase the dose of the antipsychotic. And at that point, you're chasing your tail by masking the symptoms. And obviously that's not a good thing to do. So really trying to increase the recognition and diagnosis and treatment of tardive dyskinesia, especially in the IDD population, which is at very high risk for this movement disorder. So why is TD so different in terms of its treatment and its underlying pathophysiology? Well, while we don't understand it completely, we do believe that the mechanism that's underlying TD is probably this upregulation and subsequent hypersensitivity of postsynaptic D2 receptors following the prolonged exposure to an antipsychotic or other dopamine blocking agents. So on this slide, you look from left to right. This is a dopamine neuron. And what you can see, this is normal dopamine packaging and release. So the blue is the presynaptic neuron. You can see inside that presynaptic nerve terminal, you have these circles, which are synaptic vesicles. These synaptic vesicles are responsible for the packaging and release of the specific neurotransmitter for which the neuron is. In this case, it's dopamine. And this is responsible for packaging and release of it into the synaptic cleft, as the chemical message is with the action potential delivered to the postsynaptic neuron. The VMAT2, as you can see, the little symbol there in the key, sits on these synaptic vesicles. The VMAT2 stands for vesicular monoamine oxidase transporter protein type 2. This VMAT2 is exclusive to the neurons in the central peripheral and enteric nervous system. This is, again, responsible for the storage and release of monoamines, including dopamine, serotonin, norepinephrine, epinephrine, and as well as histamine. And essentially, this is where the VMAT2 inhibitors bind and work to reduce the release of dopamine presynaptically and to basically take that abnormal signaling and make it more normal to reduce the abnormal hyperkinetic movement disorder that occurs. So again, looking at the left-hand side, normal packaging and release of dopamine. It's upon its action potential, the neurotransmitter is released into the synaptic cleft and binds to its specific postsynaptic receptor that sits on the brown postsynaptic nerve terminal. So you can see the D2 receptors sitting on the postsynaptic nerve terminal. You can see the orange dopamine neurotransmitter that's binding to its specific receptor postsynaptically, which is what it should be doing. Now you introduce an antipsychotic, which are these little semicircle teal structures that you can see there in the third slide. And what you see now is, as it should be doing, the antipsychotic is binding to its specific D2 receptor in the postsynaptic nerve terminal. So thereby it is prohibiting dopamine from binding to the D2 receptor. Well, what happens is that over time, with this prolonged use of the antipsychotic and blockade of D2, with this long-term occupation of these receptors by the antipsychotic, the receptors are going to adapt by increasing both the density and sensitivity of dopamine that is released, which then unfortunately leads to aberrant signaling and hypersignaling and these hyperkinetic abnormal movements, specifically in that nigrostriatal pathway that I talked about, or basal ganglia, that's responsible for movement. And this takes time, right? So this doesn't happen immediately upon blocking those D2 receptors. That's why this takes longer to present, which is responsible for its tardive or delayed onset nature, because this mitigation of the receptors to upregulate, it does take time. As you can see here on the last slide, you can see this upregulation, and therefore there's going to be aberrant signaling postsynaptically, leading to this abnormal hyperkinetic movement disorder. So what puts one at risk for TD? There are both treatment-related factors as well as patient-related factors. For treatment-related factors, of course, you have the cumulative exposure to antipsychotics over time. If one is treated with anticholinergics at any point, that increases their risk for tardive dyskinesia. If there's a history of any of these movement disorders in the past, that will put them at increased risk for TD. Potency of the dopamine receptor blocking agent. So the more that it binds, the tighter it binds to those D2 receptors postsynaptically, the higher the risk of TD. And then importantly, neuroleptic withdrawal emergent dyskinesias. This is important because this comes into play when, especially in the long-term care setting where these gradual dose reductions are put into place, which are, basically mandated in the long-term care setting for older individuals that are on antipsychotics. And unfortunately, when they're coming off the antipsychotic, you can see a withdrawal emergent dyskinesia. And that's because basically having the antipsychotic on board is masking the tardive dyskinesia. And once you're gradually reducing or discontinuing the antipsychotic, now you get sort of this rebound effect of dyskinesia as the drug is now coming off of those receptors. Now you have that underlying dyskinesia that's being unmasked. So that's a really important factor to look for. And unfortunately, in most cases, this is not just temporary, but it leads to, basically tardive dyskinesia chronically. So that's something to look out for if you have an individual that you're seeing that is undergoing a gradual dose reduction or a discontinuation of antipsychotic. You might think, oh, well, they're not going to have tardive dyskinesia because they're coming off the drug. But the fact is you actually might see an increase in the rate of dyskinesia as they're coming off these antipsychotics. And then patient factors include age. So the age, the higher the age, the more at risk they become. Substance abuse history, a diagnosis of mood disorder, as I mentioned, because these drugs are being utilized more so in mood disorders. There's a much increased risk in that mood disorder population for TD. Postmenopausal women, we believe that estrogen might be protective against TD for a variety of reasons. So that's why that population is at increased risk. And then unfortunately, individuals with developmental disability are also at very high risk to develop tardive dyskinesia. Of course, we know that their brains are very different and they're much more sensitive to these drugs, and they're much more sensitive to developing these movement disorders. So again, tardive dyskinesia is a very distinct movement disorder that is caused by both the first generation as well as second generation antipsychotics, but also don't forget about GI medications that block dopamine, including metoclopramide and the phenothiazine class, such as compazine or Phenergan, that's used for nausea and vomiting. Those drugs can also induce tardive dyskinesia long term. Tardive dyskinesia can affect the tongue, the jaw, the trunk, and extremities. And you can see here in this video, this lady has a bunch of different symptoms of TD. She has it in her fingers. We call that piano playing fingers. You can see she's got the movements in her face. She's got jaw movements. She's got some tongue movement inside of her mouth. She's got some high blinking rate. She's got a little bit of grimacing. She has some effects in her extremities. You can see she's got some jerking in her legs there. So she's got it in a variety of different areas of her body. So these movements can be described as choreiform, which if you have ever seen a Huntington's patient, you know that they have Huntington's chorea and have these really abnormal dance-like movements. So these movements can also be choreiform in nature with tardive dyskinesia. As an aside, the VMAT2 inhibitors are also indicated for treatment of Huntington's chorea for this reason. These movements in TD can also be athetoid in nature, meaning serpentine, sinuous, worm-like movements that are more slow and continual in nature. And then finally, these stereotypies. And this lady has a lot of them going on. Those piano playing fingers would be a stereotypy. These are purposeless, irregular, involuntary movements. They serve no purpose whatsoever. This is again, this might be difficult to differentiate between the stereotypies and the stimming that you see in, say, an autistic patient. But essentially, the way to distinguish that, and it's very difficult and it's nuanced, but with the stimming that you see with ASD, with autism patients, that tends to be in response to some sort of emotional state where they're compensating, and that's their way of dealing with whatever emotional issue that they're dealing with. It's more of a voluntary movement, but with tardive dyskinesia, it's not voluntary, it's involuntary. And oftentimes we see that with tongue movements, tongue thrusting, the tongue is coming out of the mouth, which is called the flycatcher movement, bonbon sign, where you see the tongue moving around irregularly inside the mouth constantly. You see a chewing movement, the jaw movements. You see the piano playing fingers and toes. These are all stereotypies that are associated with tardive dyskinesia. I'm going to play you some videos now of more TD movements. So this gentleman has cervical involvement, so you can see his neck. You can see those worm-like movements in his neck. You can also see it, I'll play that again, in his tongue, which is moving around inside of his mouth. It's very obvious in his neck here. You can also see some jerking movements in his elbows and arms. Now let's get a close up of his tongue. You see it's darting inside of his mouth back and forth. That's the bonbon sign, as well as the flycatcher movement where his tongue is coming out involuntarily. So this is completely involuntary. He's not doing that on purpose. It is just coming out completely involuntarily outside of his mouth. You can imagine how difficult it is for him to swallow, to perhaps speak. So he would obviously perhaps have some dysphagia associated with this. And then again, you can see he's got involvement in his shoulders, his hands. When he's standing and walking, you see these movements come out even more. This is called an activation maneuver when they're asked to stand and walk, and they're also asked to do other movements that distract them. And when they're distracted, either cognitively or physically, these movements tend to come out even more. And this is part of the Ames exam that we'll talk about in a minute. This is another case where we're seeing a lot of oral buccal lingual movements. You can see again, her jaw moving back and forth. The tongue movements are constant. Her tongue is constantly moving inside of her mouth. She's got a lot of movement in her extremities in terms of her feet. You can see that she's kind of grasping her hands. This is her way of sort of mitigating and trying to mask the symptoms that she's experiencing, but you can see a lot of those movements in her face there. Upon standing, again, this is an activation maneuver. You can see those movements come out even more in her face, in her tongue, in her trunk now. You can see when she tries to pivot, this would be a fall risk. So she's got a lot of trunk movements and extremity movements. So she would definitely be a fall risk. So it can impact these individuals in a variety of different ways. This lady has both leg and shoulder disconnect movements. You also see she's got some facial grimacing and stereotypies. Again, you can see she is shrugging involuntarily. She's got some arm movements. Her legs are moving involuntarily. Close up of her face, you can see more of this grimacing. She's got some cheek puffing. You can see, again, her eyes are blinking at a higher rate than normal. So that's, again, a good rule of thumb. She's got some head nodding. She's got, again, the shoulder shrugging. All of these are completely involuntary movements. And she's got the eyebrow raising, again, grimacing. These are all TD symptoms. Okay, so how can this affect the quality of life and the functioning of these individuals? So obviously, because of the extremities, the movement in the extremities, the trunk, this can increase the risk of falls. They can have difficulty standing, moving, and balancing. Because these movements are most commonly seen in the orofacial area, and obviously the tongue moving and the effects that it can have there, effects on swallowing, dysphagia, breathing, and speech. Oftentimes we'll see a lot of weight loss in these individuals that can occur. Obviously, there'd be a choking risk. Unfortunately, there's been some association even with cardiac metabolic morbidity associated with these movement disorders. So it can affect the other comorbidities as well in these individuals. And then psychosocially, obviously, these movements are extremely embarrassing. So that is going to impact their willingness to participate in activities, especially if they're in a resident home or facility. You know, they're not going to want to participate in OT or PT or essentially going out to dine with other individuals because they're having difficulties with their eating, drinking, with all these abnormal movements. So that can, of course, lead to social withdrawal, reduced enjoyment and satisfaction, and of course, isolation and depression. So as you can see with these movements, it can affect literally all of their ADLs. They can have difficulty dressing, showering, shaving, brushing their teeth. Obviously, the eating, drinking, the swallowing issues, the gait issues. There's just a whole host of things that can literally affect all of their ADLs and their functioning that can obviously lead to some dire consequences. And of course, it impacts their quality of life and their functioning. So how do we diagnose TD? This requires both a clinical evaluation as well as a good thorough medical history, keeping in mind that these symptoms may appear with other movement disorders at the same time. So just because they have one movement disorder does not rule out another movement disorder co-occurring. In terms of the DSM-5 criteria for TD, the movements, the abnormal movements must be present for at least 4 weeks to meet criteria. And they have to be on the offending agent, whether it's an antipsychotic or these other dopamine blocking agents, for at least 1 month in those that are 60 years and older, or 3 months in those that are younger than 60 years. In terms of when the signs of TD can develop, it can either be while they're still on the drug or within 4 weeks of withdrawal from an oral antipsychotic. As I mentioned, these would be considered withdrawal dyskinesias that can usually tend to go on to become regular tardive dyskinesia, not just withdrawal dyskinesia, and can also occur within 8 weeks of withdrawal from a long-acting injectable. This is the AIMS exam. So the AIMS is the Abnormal Involuntary Movement Scale, which is a 12-item clinician-rated scale used to assess the severity of tardive dyskinesia. This is a screening tool. This is not a diagnostic tool. So this is a way to look at an individual over time to see how severe these TD movements are. And so the idea is to get a good baseline with an AIMS exam, then at least every 6 months to do another AIMS exam to see if these movements have, if there's any new movements, if the movements have become more or less severe. And essentially you rate the individual going from head to toe, starting from the facial and oral movements all the way down to their extremities. Then you add up the AIMS total dyskinesia score, which is the sum of items 1 through 7. As you can see here, it's a scale from 0 being no movements, they're completely normal, up to the highest being severe, very high rate, very high amplitude movements. They're constant in nature. We don't have time to go into how to do an AIMS, but we have plenty of resources that we'll show you afterwards that can walk you through how to do an appropriate AIMS assessment. So how do we manage TD, especially in your population or in a long-term care setting? So this is more in the long-term care setting in terms of CMS guidelines, but really just wanted to highlight which medications that will require monitoring for TD. So if you have any individuals that are on these medications, you should be on the lookout for TD. So this slide lists all those first-generation antipsychotics, the second-generation antipsychotics. This is not comprehensive. Again, there's a lot of different second-generation drugs that have come on the market more recently. And then other dopamine receptor blocking agents, as I mentioned, including metoclopramide or Reglan, which is used for GI motility issues. And then the phenothiazines that are used for nausea and vomiting. So also be aware of those drugs. So in terms of the APA guidelines and when to monitor for signs of TD, per the APA, you should be looking for signs, clinical signs at every clinical encounter. So everyone should be on the lookout for these abnormal movements, whether it's TD or other movement disorders at every clinical encounter. In terms of specifically looking at TD symptoms, you want to do a structured assessment, as I mentioned, at baseline. So prior to starting on an antipsychotic or when you first see an individual. If they've never had an AIMS score, but they're on an antipsychotic, or if they've ever been exposed to an antipsychotic, they should get a good AIMS assessment at baseline. And then by definition, the IDD population is at high risk for TD, so they should be assessed with a structured assessment, whether that's the AIMS or the discus, at least every 6 months. Also, whenever there's new onset or exacerbation of movements detected, you should also conduct an AIMS or a discus at that time. And then other key touch points, and this again is more for the long-term care SNF setting, but initial assessment and care plan development, resident observation during ADLs. Hopefully the consultant pharmacist is doing a monthly drug regimen review to be on the lookout for these symptoms as well, And then anytime they're coming in to see you as an HCP. And then again, remember that if there's undergoing an antipsychotic dose reduction or discontinuation, be on the lookout for withdrawal emergent dyskinesias. So how do we manage TD? This is per the 2020 APA guidelines. Again, because these drugs were not available until 2017, the APA finally updated their guidelines in 2020 to reflect the fact that these drugs were available and that these patients with moderate to severe or disabling TD should receive first-line treatment with a reversible VMAT2 inhibitor, such as valbenazine or deuterated tetrabenazine. And that treatment with these VMAT2 inhibitors should also be considered in those with mild TD based on patient preference, impairment, or effect on psychosocial functioning. Importantly, the APA guidelines also highlight that changing the antipsychotic dose type is not recommended for TD treatment, and there's insufficient evidence for this to help at all. And again, keeping in mind that dose reduction may actually contribute to a relapse or exacerbation of TD symptoms due to that withdrawal dyskinesia phenomenon. And then importantly, again, anticholinergics such as benztropine, Artane, diphenhydramine or Benadryl are not recommended and may actually worsen in addition to producing significant anticholinergic side effects. And again, these drugs can increase the risk for TD down the line as well. And this is just reiterating from both the AAN as well as the APA that anticholinergics should not be utilized. They can make it worse and also are associated with the risk of dementia. Why is this? It's because in the case of drug-induced Parkinsonism, as you can see here, in normal circumstances, the brain has a very delicate balance between dopamine and acetylcholine. They're in this balance. In drug-induced Parkinsonism, what happens when you're adding an antipsychotic, dopamine blocker, now you're getting reduced dopamine signaling, again, in that Nagel-Schreiber pathway, which is leading to this movement disorder called drug-induced Parkinsonism, which is a hypokinetic movement disorder. And now acetylcholine is becoming more active because there's not enough dopamine. In that case, when you treat with an anticholinergic, you bring that back into balance because you're giving an anticholinergic. So you're balancing out that excessive, that overly active acetylcholine by giving an anticholinergic, bringing the brain back into balance and hopefully treating the movement disorder. When you look at TD, it's the opposite. So there's already a hypersensitivity of dopamine, right? And that's what's causing this aberrant hyperkinetic movement. And now there's not enough anticholinergic. So if you give an anticholinergic, you're making that imbalance worse. So you're actually exacerbating the imbalance and making the movements worse in that case. So this is just a summary of what happens with the different movement disorders when you add an anticholinergic. The hyperkinetic movement disorders being tardive dyskinesia and akathisia with TD. Adding an anticholinergic can worsen it. Discontinuing it may improve some of the movements with acute akathisia. Insufficient data to use anticholinergics, which is why propranolol or beta blockers are recommended. Drug-induced Parkinsonism and acute dystonia are considered those hypokinetic movement disorders. Both of these movement disorders can be improved with the use of anticholinergics. And again, just keep in mind that anticholinergics cause a whole host of adverse drug events, especially in the IDD population. It's very, very sensitive to these drugs. They're already cognitively impaired, and these drugs can make that worse, can cause memory impairment, delirium, dementia, psychosis, confusion, visual hallucinations, along with all the peripheral side effects that can be induced by utilizing these anticholinergics, including urinary retention, dysuria, and especially constipation is a huge one in this IDD population. So again, you want to use anticholinergics sparingly. And if you have to use an anticholinergic to treat one of these movement disorders like dystonia or Parkinsonism, you only want to treat for as long as the symptoms are present, and you want to titrate down, taper off as soon as possible. In fact, there are some guidelines that say you shouldn't be on an anticholinergics for longer than 3 months total. And we know that especially in the IDD population, a lot of these individuals have been on anticholinergics long-term, and we don't even know why. So we really need to look at the indication for these drugs and to get them off and taper them off as soon as possible. Looking at the different drugs, the VMAT2 inhibitors, and individual considerations for when to treat and which drug to choose. So obviously you want to look for the preference for the formulation, the dosing schedule, including titration issues, the available formulations and dosing schedules, clinical evidence, individual patient factors, including hepatic impairment, and then clinical data, including concomitant medications. So real quick to run through the PI information, both of these drugs, valbenazine and deutetratetrabenazine, are indicated for the treatment of adults with tardive dyskinesia as well as chorea associated with Huntington's disease. Because of the risk of depression and suicidality in Huntington's disease in general, these patients are at very high risk for suicidality and depression. There is a boxed warning for the risk of depression and suicidality in the Huntington's population in particular. You can see here the dosing and administration for the two drugs, and this next slide will make it a little bit more clear. With valbenazine or Ingrezza, it does not require titration to reach an effective dose. For the treatment of TD, as you can see here, the starting dose is the effective dose, which is 40 milligrams once daily. At week 2, you can increase up to 60 or 80 milligrams. And you can maintain that dose. And again, that 40 milligram dose, which is a starting dose, is an effective dose, but you can increase as needed up to 60 or 80 milligrams once daily. With deutetratetrabenazine, you can see there's a much more complicated titration schedule, and in some instances may take up to 6 weeks to reach the required effective dose. There's also some significant differences in special populations. So for instance, valbenazine or Ingrezza does not undergo renal clearance. There's no dose adjustment required at all for renal impairment with valbenazine or Ingrezza. Deutetratetrabenazine, that was not studied. For hepatic impairment, there's no dose adjustment required for her mild hepatic impairment with Ingrezza, the recommended dose being 40 milligrams once daily just for moderate or severe hepatic impairment. But with deutetratetrabenazine, it's actually contraindicated with hepatic impairment. So if you have an individual that has some level of hepatic impairment, you want to avoid the use of tetrabenazine and deutetratetrabenazine. Geriatric use, we do have safety and effectiveness data in our clinical trials with valbenazine. There were insufficient numbers in the deutetratetrabenazine trials to make any conclusions. Anticholinergics were permitted. They were not an exclusion in the valbenazine clinical trials. However, they were not allowed. They were excluded in the deutetratetrabenazine trials. And then prolactin is another one of those issues. There's a balance between prolactin and dopamine in the brain, and there can be some dose-related increase in prolactin observed with these drugs. However, there's no restrictions or warnings or precautions in the valbenazine label, whereas there is warning and precaution for hyperprolactinemia in the tetrabenazine trials. Hepatic impairment, just going a little bit deeper. Again, no dose adjustment for mild with valbenazine, 40 milligrams for moderate to severe impairment. And the reason for that is listed here. With a single dose, the Cmax was less than 2 to 3-fold higher in the valbenazine trials. Whereas you can see here, it's contraindicated with deutetrabenazine as well as tetrabenazine because the Cmax was up to almost 190-fold higher in hepatically impaired subjects. So that's why there's a contraindication with the deutetratetrabenazine. There's also some drug-drug interactions to be aware of with strong 2D6 inhibitors. You can get an increase in exposure with valbenazine. So the recommended dose is just 40 milligrams once daily. So no greater than 40 milligrams for that 2D6 inhibitor case. So examples of that would be bupropion or Wellbutrin, Paxil, Prozac, etc. With deutetrabenazine, you can see 550% increase in exposure to active metabolites. So there is a dose recommendation, should not exceed 36 milligrams per day. 3A4 inhibitors, there is an exposure increase to the active metabolite with valbenazine. Again, reduce the dose to 40 milligrams, which is still an effective dose. 3A4 inducers, the most common you might see is carbamazepine or Tegretol. You can see a decrease in exposure, and concomitant use is not recommended per the package insert. However, it's really because there's just a reduced exposure of the active metabolite. There's no real safety issue there. With deutetratetrabenazine, the concomitant 3A4 medications and the effects of those have not been disclosed to date. There are some other interactions with P-glycoprotein substrates. The one with valbenazine would be digoxin. So there is a drug interaction with digoxin. And so taking digoxin with valbenazine, you need to monitor and adjust the digoxin dose if needed. However, that's the only other P-glycoprotein substrate that's affected. And finally, with the formulations and in terms of food requirements, deutetrabenazine must be taken with food. That's the regular release formulation. The XR formulation can be given without regard to food. So it can be given with or without food. Deuterated tetrabenazine must be swallowed whole, and you cannot crush or chew or break the tablets. With Ingrezza, the formulation is very different. There's also a sprinkle formulation, and that can be given. So if you have an individual that has a large pill burden and they prefer not to swallow, or if they have dysphagia or difficulty swallowing, there is this sprinkle formulation that we have. It's given once daily, sprinkled on soft food. You can also take the capsule whole with water. You just want to make sure you don't crush or chew the sprinkle formulation. The regular Ingrezza can be given with or without food. It's not affected by food at all. And as an aside, you can actually give the regular release Ingrezza via G-tube, whereas you cannot give Austedo or deuterated tetrabenazine at all via G-tube. And finally, I just want to close with the patient case. So really quick, so you can see the effects of these drugs. So this individual you saw earlier, her baseline AIM score was 20. Interestingly, you can see she's not even on an antipsychotic at the time that she was enrolled into the clinical trial. However, she was on Artane, which is an anticholinergic, and it's probably a given that as a bipolar patient, she was exposed to an antipsychotic at some point in her history. And so along with that, along with the Artane, she obviously has tardive dyskinesia. Now she was randomized to receive 80 milligrams of valbenazine, and this is now her at week 6 of valbenazine 80 milligrams. Her AIM score went from 20 down to 7, and her movements are barely perceptible. You can see a little bit of movement in her toes still. You can see there's hardly any movement whatsoever in her face. Very little movement whatsoever. She's smiling. She's got expression. And you can see up close, you remember how she had all those movements in her jaw. Her tongue was moving inside of her mouth constantly. You can see there she's able to stand still. She's got some rocking still, which is why she's got that score of 7. But overall, she was doing really, really well after just 6 weeks of valbenazine. And then at week 48, so that she was part of our long-term trial, you can see now she's down to a score of 5. So doing even better after 48 weeks on valbenazine. Again, the movements are barely perceptible. She's actually got a slight smile. You can barely see a little bit of tongue movement inside there. Again, she's able to stand, and she would not be a fall risk at this point. So unfortunately, these drugs are not disease modifying. They are symptomatic treatments. So once you come off these drugs, unfortunately, the individual will go back to baseline. So this was her 4 weeks after she was discontinued from the valbenazine. So unfortunately, she went right back to her baseline AIM score after discontinuation. So important safety information, as I mentioned, the depression and suicidality in patients with Huntington's disease, the contraindications with Ingrezza and Ingrezza Sprinkle. The only contraindication is hypersensitivity. There is warning and precautions for hypersensitivity, as well as somnolence and sedation. Somnolence and sedation are the most common side effects with Ingrezza. This Ingrezza may prolong the QT interval, although the degree is not clinically significant at normal concentrations, at normal dosing. But if you have an individual that has a history of prolonged QT or a history of congenital long QT syndrome or arrhythmias associated with prolonged QT, you want to avoid the use of these agents, be very careful. NMS, very, very rarely seen. Parkinsonism may sometimes be observed with all the VMAT2 inhibitors. If that's the case, it's recommended to reduce the dose or discontinue the Ingrezza if it's significant. And as I mentioned, the most common adverse event is somnolence. So as a summary, again, we talked about how to treat these different movement disorders. With acute dystonia, anticholinergics are the drug of choice. Akathisia, it's beta blockers, drug-induced Parkinsonism, anticholinergics, amantadine if you want to avoid the anticholinergic class, and then tardive dyskinesia in specific, it's only VMAT2 inhibitors are indicated and FDA approved for the treatment of TD. Again, differential diagnosis is necessary for appropriate treatment, remembering that TD can often coexist with other movement disorders and requires specific management. One size does not fit all, and the use of multiple treatment options may be necessary with multiple different movement disorders. And importantly, anticholinergics such as benztropine should not be used for the treatment of TD. So with that, we'll close with any questions, and wanted to also show you your hub, the Mighty Networks hub. So I guess I can stop sharing here and see first if there are any questions and if you want to bring up the hub.
Yeah, so our one question so far actually kind of might be related to the hub. It was about if these slides would be available after the session, and if so, where and how. And then also, I guess just more generally, um, the hub will show us all of these resources that we kind of have.
Yes, in fact, the hub will have the most comprehensive resources that, and we'll show you that in a second here.
All right, we want to go ahead and show the hub right now.
Yes.
All righty. So I'm going to share my screen. This is our member platform. So if you are a member of AADMD, this would be very familiar to you. When you log on to the normal, just AADMD landing page, this is what you see. And it's like a big Facebook feed here with all of our information. What we have prepared for you guys, which is really exciting, is we have created an hub. It's a Neurocrine Tardive Dyskinesia hub. And if you scroll down on the left side of your menu, you'll find it under our partner organizations. And so we've built out this hub where you guys can network, ask questions. There's a Facebook kind of feed right here if you want to post anything. You can see what other members join this hub. But most importantly, this is where we're housing all of our TD resources from Neurocrine. So do you want to take us through these resources?
Yes, if you can click on them. So the first one is just looking at the burden and impact of TD. So that's what we obviously went through this evening. And the abnormal movement questionnaire, this is a really cool tool that might be utilized. I would definitely encourage the dental professionals that are on to perhaps look at this to see if it might be a useful tool for you to screen your patients when they come in for a dental visit. It's basically an easy way to look at and circle on what we call the blue man. Any areas where you notice abnormal movements. And you don't necessarily need to know what or diagnose what the movement is, but if you can just circle on the figure where these movements are occurring, and then with the different circles there, jot down where you're seeing the movements, whether it's the head, face, torso, upper limbs, lower limbs. And then the flip side, the second page, looks at the impact of the movements. So is it affecting them physically in terms of their ADLs, speaking, eating, drinking, getting dressed, walking? Is there an increased risk of falls? Are they being socially impacted, interacting with their families, social relationships, participating in groups, and their emotional impact overall? So we love to have this tool available for other healthcare professionals that may not be, experts, but it's a way to identify, screen for these abnormal movements, and then use that as a referral tool when they go see whether it's a neuro or a psych specialist that might be better equipped to actually diagnose what the movements are and diagnose and treat the TD. This is the AIMS scorecard. So this is essentially what we showed you, the AIMS scale. So if you're interested in learning more about how to do an AIMS scale, we've got the handout here, and it kind of walks you through how to conduct an AIMS. So it walks you through all the different steps there. And then, yeah, this one is basically walking you through the different drug-induced movement disorders and how to differentiate amongst them. And then the final one there is the AIMS instructional booklet. So Again, it walks you through how to conduct an AIMS exam, head to toe, and then how to interpret. And along with that, we also have a companion website called mind-td.com. And mind-td.com is referenced in a lot of these different resources. There it is right there. So that website is extremely comprehensive. It has every resource you can possibly imagine when it comes to drug-induced movement disorders as well as tardive dyskinesia. It walks you through differential diagnosis. It has cases. It has patient videos. It has podcasts, PowerPoint presentations. It is an amazing resource. I highly recommend that you go to that site. It really can answer any and most of your questions. I'm quite confident. So thank you for that. Any other questions? I know we went over a little bit. I apologize.
That's okay. I think we just had the one question in the Q&A box. Will the slides be available after this session?
I really would prefer that you go to the MindTD website and those resources on the hub and see if that helps to address some of your questions. If it doesn't, please reach out to me. You can either have Courtney reach out to me or you can email me directly at kdavies@neurocrine.com, and I can submit a request to medical information if you want the slides.
All right. Any other questions, comments? Riley, anything?
No, thank you so much. I think this was very informative as a second year medical student. It's relative to what we're learning, so it was a great talk.
Excellent. Excellent. Well, thank you
All
so
right.
much for your time.
Yeah, and thanks so much. I just want to remind everyone that we do have a conference in June, and so we'd love to see all of you guys there. And if you want to go to that website, it's aadmdconference.com, and you'll find all of the information. And we thank you so much for attending, and we'll see you next time. Thanks, everyone.
Thank you all.